blown like crazy to try to push it out. We talked about retractions. Retractions they're really creepy. When you see a baby who's breathing in, but the chest goes in the opposite direction, it's very scary. Accessory muscle use. So you can see that from all the way up here. You could see the neck muscles, the sternocleidomastoid muscles. You could see the pectoralis major, abdominal muscles. So from here to here, you can see intense work of breathing when they are having difficulty. Asymmetric chest wall movement. You could see that with flail chest. A series of quick breaths followed by a prolonged expiration. That's called chain stoking. I know we've talked about that one before. That's where a patient is breathing really fast and then all of a sudden they stop. And then they breathe really fast and then they stop. These are patients who have serious head injuries. They could have increased intracranial pressure, meningitis patients, even patients who have a stroke. This could result in them. Also, opioids, good old opioids, right? So it's altering their central nervous system. You know, also about Kussmaul respirations. You remember the Kussmaul respirations in a patient who has diabetic ketoacidosis? What are those respirations like? It's really deep and shallow. Remember a patient who has diabetic ketoacidosis, what do we smell?
It's that fruit.
And sometimes these patients that are confused with patients who are drinking, so it does smell like alcohol. So we have to make sure we're assessing our patient again. And look at your scene, look at around you and see how the patient is presenting it in the place that they're presenting it. How about skin that's pale, diaphoretic? Okay, a little bit about pulse ox. These are the pulse oxes that we have on the beach. You guys have a different one, I think, right? Don't you have like a little like this with a cord?
Yeah, most of the time we have both. If we're like on our first out, we have both.
Okay.
So,
Okay. So it will read the oxygen saturation, your SpO2, as well as your heart rate. And if you look here, we can change it. If you push that little button on it, you can change each screen. So you're looking at the pleth, you're actually looking at the heart rate. And if you're looking at this, you can see if it's regular or not. Okay? So we know that it does, it reads the hemoglobin that is saturated with oxygen. It's designed only for pulsating blood vessels, and they're arterial, they're not the venous blood. It measures the pulse, like I mentioned. So less than 90%, and in respiratory distress, we do aggressively treat this patient. When I'm on the beach, it's hard. These are some of how you get the erroneous readings. Where I can't see, I have to cover over because of the sunlight, and my Maui gyms too. I can't see because of the polarized, is that what they are, glasses? Yeah. So I just have to pull those up, otherwise they'll never see it. If the patient's moving, poor perfusion, nail polish, we know that in women, that dark nail polish, the gel polish or acrylic polish. If they have an abnormal hemoglobin, and that would be your carboxyhemoglobin. So we know that carbon dioxide binds to the hemoglobin 250 times more readily than it does oxygen. But can we misread that? Yeah. So again, you're looking at your scene, you're looking at your patient. This is pretty basic, but it's really important to remind. If we have a patient who's in a supine position, is that the most ideal position for a patient who's having respiratory difficulty? Not really. What position would be best for a patient with respiratory difficulty?
Seated.
Sitting them up. Yeah. Yeah. Either we call it semi-Fowlers or high Fowlers. So sitting straight up or sitting, reclined just a little bit. When would we put our patient in a recovery position? What kind of patient would we do that for?
If they're
a drowning patient
And what would be the purpose of putting them in a recovery position in the left lateral recumbent position?
so they won't choke on fluids.
Yeah, exactly. Even a post-ictal patient, that one that we had on the beach that day, yeah. However, we just scooped her up quickly. Remember too, with drowning patients, they're gonna have an excess amount of white foam. We're gonna blow through that foam. You're not gonna suction that foam. You'll suction the vomitus, but not the foam. Just keep bagging through the foam. The head tilt chin lift maneuver, we talked about that. If you have a obstruction, the tongue is obstructing, we can reposition. And the jaw thrust maneuver would be when the patient has a spinal injury. Talk a bit about suctioning. And we're going to go over that as well. I brought one from the college over there that's a little bit different than the one we have. But ideally, we want to clear the patient's airway after we position the patient. If we hear gurgling, we're going to suction. We do have to make sure that we have enough power to suction, and you want to have at least 300, if not greater, millimeters of mercury for adequate suctioning. And with your Yankauer, you want to make sure that you do have adequate suction by covering over that little hole there. We know that if a patient aspirates, the mortality rate increases. So when you are using a Yankauer, the hard tip, as well as the whistle tip, the small, tiny little one, we do have to measure, and a lot of us don't do that, I realize. So you're going to measure from the corner of the mouth to your ear, and that's as deep as you're going to go when you're suctioning for that patient. So when you measure it, we'll go over it with a Yankauer, but just hold your finger there and just know that you're not going to go any deeper. So as we suction our patient, how are we going to do it?
You don't want to spend much time doing it, maybe 5 seconds,
So for an adult, it would be no more than 15 seconds.
15 seconds, okay.
How about a child?
10 or less?
10, yeah, exactly. Because we're sucking out that oxygen, so we want to try to get it. Try to stay as close to the side of the mouth as you can, and you're suctioning on your way out. We're going to go over airway adjuncts, the OPAs, the NPAs, and the iGel. And just a quick review that we would use an OPA in an unresponsive patient only with no gag reflex. I would never put one of these in a patient who is semi-conscious because you know that they're going to grab it and or gag and vomit. The advantages are that it's non-invasive, it's easily placed, and it does keep the glottis, the tongue from covering over and their airway. Disadvantages is it doesn't protect against aspiration, and you may cause a gag reflex when you put it in. Now, an NPA, unresponsive patients with an ultraparental status who do have an intact gag reflex, it's easier to put them in these patients. However, make sure you do lubricate them, and we'll go over it in our skills training as well. Contraindications would be any nasal fracture, facial mouth fracture, skull fracture, anything like that. We definitely don't want to use it. We can suction through it. I've never suctioned through an NPA, but it can be done. And just know that it does not protect against aspiration, and you can cause a nosebleed. That's very simple. So I'll just go over this real quick for an iGel.
First, decide on the most appropriate size of iGel 02 to use. Correct size is normally determined by weight. Open the iGel 02 rhesus pack, remove the inner tray containing the lubricant, airway support strap and suction tube, and place the contents to one side within easy reach. Place a small bolus of lubricant on the base of the inner side of the main shell of the packaging. Touching no lower than the bite block of the iGel 02, lubricate the back, sides and front of the cuff with a thin layer of lubricant. Ensure any excess is removed. Grasp the lubricated iGel 02 firmly along the integral bite block. The ideal patient position for insertion is with the head extended and the neck flexed. But if this is not possible or is inappropriate for the patient, then iGel 02 can be inserted with the head in a neutral orientation. A proficient user can achieve insertion of iGel 02 in less than 5 seconds. Introduce the leading soft tip into the mouth of the patient in a direction towards the hard palate. It is not necessary to insert fingers into the patient's mouth. Glide the device downwards and backwards along the hard palate with a continuous but gentle push until a definitive resistance is felt. Do not apply excessive force. The tip of the airway should be located into the upper esophageal opening. The cuff should be located against the laryngeal framework. The epiglottis should be held in place by the epiglottic rest. The gastric channel should open into the esophagus, and the incisors should be resting on the integral bite block. The iGel O2 should now be secured in place with the airway support strap, or taped down from maxilla to maxilla. To use the airway support strap, slide it under the patient's neck and secure it to the iGel O2 hook ring, using the appropriate holes on the strap. Ensure there is sufficient tension to hold the iGel O2 securely in place, but not excessive tension that may cause trauma to the patient. Some adjustment of the strap may be needed. A resuscitation bag can then be connected to the iGel O2 and ventilation can begin.
Okay. And
If your
we're going to go over that as well in the skills section. Almost done. One more thing. Talking about supplemental oxygen devices, and we'll definitely go over those with our skills. We'll talk about the non-rebreather mask. High flow oxygen is what you're going to be using, 15 liters. It will provide 90% of inspired oxygen. A nasal cannula, we use 1 to 6 liters, and it delivers 24 to 44% oxygen concentration. And a bag valve mask will deliver 100% when you give 15 liters of oxygen. When we're assisting a patient in respiratory distress or failure, we're going to explain the procedure to the patient. And you're going to put the mask over the mouth and the nose. And with this, we're going to squeeze the bag every time the patient inhales. And if the patient doesn't have enough effort to inhale deeply enough, we can add a little bit more. We want to maintain the same rate as the patient. Do this for like 5 to 15 assisted breaths, see how they tolerate it. And if they're not tolerating, we have to take over, then we'll take over. So that's something that we'll practice over here on our mannequin as well. The last of all is the foreign body airway obstruction. This is the new guideline for the 2025 American Heart Association, and it has changed, and that's why I wanted to bring this in. So if you see universal sign, patient coughing, right, let them cough. Continue to check for signs of foreign body airway obstruction on this patient. If it turns severe and the patient is weak and you don't have see any absent or any coughing in this patient, they're unable to speak, they're cyanotic, they're apneic, and now they have an altered mental status. If the patient becomes unresponsive, we want to start CPR. And if the patient becomes unresponsive, we're starting with chest compressions first. But if they are continuing to grab and able to try to expel it themselves, we're going to give this patient 5 back blows. This is an adult, this has changed. So 5 back blows and then 5 abdominal thrusts. So the same as we were doing before, where you're putting your thumb in and doing up like this, okay? We're going to continue doing this until either the object is expelled or they pass out, and then we just take over. Each time we try to give this patient a breath, we want to check the airway to make sure if we can grab it, we can grab it. So a pregnant woman or a very obese person that we cannot get our arms around, then you can do the chest thrust. Okay, so you're going to do the 5 back blows, but you will be doing the chest thrust instead. Okay. So let's just go over real quick what we talked about. We talked about the respiratory system, the function of it, the difference between ventilation and respiration, how often a patient's airway and breathing should be assessed, whether the patient's airway is patent or not, and how did we evaluate that. Was the patient breathing adequately? Why or not? Why not? We talked about cyanosis and what it indicates, where we can locate signs of cyanosis on a dark-skinned person. What does the oxygen saturation indicate? We talked about snoring respirations and how we can fix that. And the dangers of hyperventilating our patient. With that, I'm not sure we even talked about that, but if we're hyperventilating a patient, what could we cause? Putting too much air, too much tidal volume, too fast, make them vomit in most cases. Okay, and then the dangers of aspiration are there. And we did talk about respiratory failure and the difference between respiratory failure and respiratory arrest. We are done. Do you have any questions? Do you want to take a break real quick? Very good.
Do you mind if I get some
Yeah, we can take a break.
No, I don't.
Okay.
No, not at all. So when you come back, what I'll have you do is go ahead and take this quiz, because this is reflective of what I just went over.
Mhm.
Okay? And do that, and we'll review the quiz when you come back.
Okay.
That's it. Can we stay 10 minutes? I just do this for you guys, because I...
Yes.